to talk to those of you who are not radiologists about the recent advances in CT and MRI, because I think it's important when we're talking about state-of-the-art ultrasound, we should also talk about state-of-the-art CT and MRI. The most important innovation of CT in the last 10 years was the introduction of multi-slice CT. We started with 2 and then 4 slices, and we are now up to 256 slices. This is the number of slices that you obtain per rotation. In fact, it's per 180 degree, so it's per half rotation. And that really has made a difference. CT was considered to be almost a dead modality before the advent of first spiral and then multi-slice CT. People used to think that CT has been around, it does a good job, but the future will be in MRI. But those predictions have turned out to be completely wrong. In fact, the future is of radiology is just as much CT as MRI, and the number of CT scanners around the world and the number of CT examinations around the world is continuously increasing. What multi-slice CT does, it makes it much, much faster. We are now, for an abdominal scan, is now typically obtained in about 10, maybe even 5 seconds. This used to be about 5 minutes just over 10 years ago. So we're seeing tremendous change there. With those multiple thin sections, we get much better spatial resolution, and of course we can also increase our scan range. And the increased speed allows us to be much more precise with our contrast media phases, and also to increase the number of phases if this is what we want to do. Of course, movement artifacts are suppressed. The patient doesn't necessarily have to hold his breath during a CT scan these days. Very thin slices, which allow us to perform multiplanar reconstructions. We can now image in all possible slices through the body without any loss of image quality. And of course, the scan volume allows us to perform, if you like, whole body CT, but certainly to do a neck, chest, and abdomen in one go with one amount of contrast is routine practice these days. I won't go into the details of the contrast phases, but obviously there is the temptation now, as everything is so fast, to perform more and more phases of contrast. This is something we have to withstand in the interest of radiation protection. There are obviously different indications, metastasis, hypovascular metastasis first or follow-up, and so on. And you can see that the portal venous phase is really the backbone of everything. Quite often we would add an arterial phase, which doesn't have to be a dual arterial phase. Only in the when HCC is at question, one may want to resort to this. And then delayed scan is also something that is optional in most cases. So typically, the typical CT examination would be an arterial and a portal venous phase. To show you the value of the delayed phase, I'm showing you an image here of 2 very similar looking, very small, sub-centimeter focal liver lesions. And you would probably say, yes, I think this is a cyst, but I wouldn't be sure if this is a cyst as well or not. I don't think you can tell on this portal venous phase image. But if you do a delayed phase image, then you can see that this lesion here, which is a metastasis, almost completely disappears because it gradually fills with a non-specific contrast medium, different mechanism than with contrast-enhanced ultrasound. Of course, remember, metastases are wash out on contrast-enhanced ultrasound. Here it's different because this slowly diffuses into the tissue. This leaves this diffuses into the extracellular space, and therefore can be differentiated from this small cyst. So this is one of the applications where late phase imaging is helpful. The value of multiplanar reconstructions, I've shown you this case before yesterday. Here is an obvious metastasis, but we did not see an additional metastasis at the time on the axial sections. But if you reconstruct this in the coronal plane, then this lesion, which you can just sort of fantasize here, becomes reality and is actually quite obvious. So it is quite useful to review your abdominal CT scans, not only in the axial but also in the coronal and sometimes sagittal plane. How does the increased spatial resolution affect detection of focal liver lesions? Here is work from Raffaella Basilico, and you can see by going from 5 millimeter sections, which used to be routine, sort of high-end routine, if you like, for a single slice, going to 3 millimeters, the number of lesions detected increases really quite significantly, and this is also true for the other studies I have here. CT, when you do it during the arterial phase, also gives you a lot of information on the vessels. CT angiography, of course, is a standard routine procedure now, and this is all in the data of your arterial phase scan, and if you perform the adequate reconstructions, 3D reconstructions, you can extract the angiographic information from your image, and this allows you, for example, to plan a resection with these software tools, quite helpful sometimes for the surgeons if they're not sure where to resect and if a tumor is still resectable or not. So this can be very helpful. So this was CT, state-of-the-art CT at a glance. So let's move over to MRI. When it comes to liver imaging, to my mind, the most important innovation has been the introduction of respiratory triggering during T2-weighted imaging. All of you will remember these horrible-looking T2-weighted images. They used to be quite thick sections, typically 8 millimeters, sometimes even with a gap between the slices. Often you had respiratory artifacts with these bright streaks over the liver. And T2-weighted imaging really used to be a bit a matter of luck. Sometimes it worked quite well, but a lot of patients who couldn't hold their breath well, that you really didn't get very nice results. Now this has been solved, and the way this works, there are really two ways. You can either just put a belt around the abdomen or chest of the patient, and this belt has a sensor for stress. So every time the patient breathes in, it gives a signal, and then the image acquisition will only be performed in the in or expiratory phase. And the alternative is to use a navigator technique where a small sample of liver tissue adjacent to the diaphragm will be tagged magnetically, if you like, and then will be followed by the scanner as it moves up and down, and the scanner will only acquire images once it's in this red here, so once it's above a certain position, then this will equal the inspiratory phase, and the acquisition is then performed. And this is the result. Here is a conventional T2-weighted image, which I think is really quite nice. It's none of those horrible images I was telling about before, but if you compare this in the same patient, you can see how much more detail, for example, like the bile ducts here, or vessels rather. So this really is a dramatic improvement in image quality. And it's a bit dark, I'm afraid, but this is a typical data set of a T2-weighted image acquired in 4 millimeter slices, so we're getting really much thinner now also with T2, and it takes about 5 to 10 minutes to acquire these images. Here is another example of what this does for you in terms of the information that you're getting. This is a conventional T2 breath hold image in a patient with cirrhosis. So there are some signs here of fibrosis and also some regenerating. Look at this very same patient with a navigator technique. It now becomes obvious how much fibrosis there is in this patient with all these scar septa throughout the liver. So really, I think this is a dramatic improvement. Now let's move on to T1 weighted imaging. T1 weighted imaging is, of course, also the sequence that we use for contrast enhancement. And again, significant advances have been made. With modern scanners, it is now possible to acquire these dynamic images at very thin sections, 3 millimeter slices. This is something that is now approaching the CT arena. Before, again, the slice used to be much thicker. This still takes about 23 seconds to acquire, but it is routine, and it routinely provides really excellent images. We're moving from the technical advances to the contrast media, and contrast media well, you know all about from ultrasound, you know how important it is, and this also applies to CT and MRI. And the contrast media in MRI are a little bit more numerous than in CT. In CT, you essentially have non-specific contrast media. They have different names and different brands, but they're all the same, more or less. They all do the same. In MRI it's different. First, you have the non-specific extracellular contrast media. They behave like CT contrast media. They first go into the vascular space, but they quickly diffuse out into the interstitial fluid compartment. These are the working horses of MR. They're used for everything, really. But for the liver, there are liver-specific contrast media. And some of them are agents which are T2 agents, and they render the normal liver parenchyma darker than without contrast medium. So it reduces the signal intensity with the result that everything that does not take up the contrast medium stands out as a bright lesion. These are the typical SPIO, supraparagmatic iron oxide particles. They get phagocytosed by the Kupffer cells, and here are some examples. Now, the more recent liver-specific contrast agents, and there are 3 of them on the market, are T1 agents. So they increase the signal intensity on T1-weighted imaging. We're always talking late phase, by the way. This typically takes 10 to 20 minutes to be taken up by the liver cells or by the liver. So this is delayed imaging at 10 to 20 minutes. And these T1 images, they mimic bile, really. They get transported like the bile, and therefore they get taken up by the hepatocytes, and they also get excreted into the bile ducts. This is why bile ducts are bright on liver-specific imaging when you use one of these agents at 20 minutes. And this is quite a nice intravital microscopy. This is a Kupffer cell you're seeing here, and you will see those small particles coming in. Here, these little brownish dots, and you can see how they get specifically absorbed by the principle of liver imaging with SPIO. And here is the effect in a patient with 2 metastases seen on conventional T2-weighted imaging, and then you can see how much better these metastases are delineated after contrast, and previously not visualized are now really easy to see. So these are some technical advances I wanted to tell you about, and now I'm moving on, and this is really the basis for all 3 talks today. And I'm now moving on to the specific topic of CT and MR of benign liver lesions. PET was also on the program. PET has no role in benign liver lesions whatsoever. So also I don't do PET, so I'm not going to mention it here. I will mention PET briefly in the metastasis talk later on. Characterization of an imaging of hemangioma with CT and MR is typically really quite easy. You all know these images of the peripheral nodular enhancement and then the gradual centripetal fill-in. This was incomplete, by the way, and this is what the previous talk was about. Sometimes they show areas of central fibrosis or thrombosis, and not all of them fill completely, but it doesn't matter. If you see this, this completely suffices for a reliable diagnosis of hemangioma. And indeed, here is a small hemangioma shown on a coronal plane different patient, which shows the typical peripheral nodular enhancement. If you see this on an arterial phase, you know it's a hemangioma. You don't really need to wait. Obviously, you should do it for completeness sake, but if you see this, you can be 99% sure that this is a hemangioma and nothing else. And this also refers, of course, to contrast-enhanced ultrasound. Here is a dynamic T1-weighted MR image in the arterial portal venous and delayed phase of a hemangioma, and it shows the exact same features. Now, sometimes this is not as clear-cut, and I'll show you a case of this very soon. And MR has one advantage over all the other images here. It gives you very characteristic information also on the T2. And you can see here this hemangioma on the T2, it's as bright as the gallbladder. So it has fluid-like signal intensity. And this is very, very reassuring. And indeed, there are people who say, if you see this, you don't need to give contrast, because it can only be either a cyst or a hemangioma, both of which don't really matter. So arguably, you don't even need to give contrast with MRI to characterize a hemangioma. Look at this case here. Concentrate on this line of images first. This is a patient I saw this week. She had an MR scan of this focal liver lesion 5 years ago. This is the MR scan. And then she came for contrast. She had an incidental large focal liver lesion detected after the birth of her first child. And this is what this lesion looked like on contrast enhancement. Now, first it looks funny, and you think, is this focal nodular hyperplasia? Because it looks like a sort of a radiating feeding artery. But then you can see it gradually, the lesion gradually fills, and eventually this is, I think, at 5 minutes, completely filled with contrast medium. Now, thinking about it, this is obviously cannot be an FNH, because FNH fills within seconds and not within minutes. So this is likely to be very likely to be a hemangioma. The lesion hasn't grown in 5 years, it's stable, so this confirms the diagnosis, and it probably is a capillary hemangioma rather than a cavernous hemangioma. They typically look a bit more like a web, and the contrast enhancement isn't so much typically from the periphery, but it may start somewhere in the center. And what is very helpful here is the T2 weighted image again. You can see it's a huge lesion really. It has multiple additional lesions around it, so it's almost like a hemangiomatosis, at least of the right lobe of the liver, and it's bright signal on T2, and that is very reassuring. And if you combine this with this, then I think the diagnosis of a hemangioma is correctly made. FNH is, again, it's a very typical tumor. You've seen the cross-sections earlier on, and it is bright on the arterial phase, shows hyperenhancement. It's a hypervascular tumor, and it gradually washes out, but this typically, the signal enhancement is about the same in the portal venous and also in the later phases, the same as in normal liver parenchyma. If it's like this with a large central scar, then it's really very easy also on CT. Sometimes not so easy. This one, for example, is not so clear-cut because it doesn't really have a central scar. All you can see, it's a hypervascular tumor. You can see a feeding artery here. You can probably fantasize a sort of a stellate appearance here. There's just a suggestion of it, and then the lesion disappears in the portal venous phase. And this is the type of lesion that is not easily characterized by CT. This is where you can say, well, this looks like an FNH, but it could, of course, be a hypervascular metastasis, or possibly, if there were cirrhosis, it could even be an HCC. So these are the cases where CT is not doing terribly well. MR is better for FNH because it shows the central scar better, and it has a typical criterion, and this is the gradual accumulation of contrast medium in the central scar over time. This is a very specific sign for FNH and should be used, and is one of the reasons why MR should be preferred over CT for characterization of benign lesions, and in particular FNH. Now the important differential diagnosis is adenoma. Adenoma is exceedingly rare in comparison to FNH, but it still happens, and especially the internists are often concerned, are you sure that this is really an FNH? Could this not be an adenoma? And the answer is, quite often one cannot be entirely sure based on imaging, and especially based on CT and contrast-enhanced ultrasound. And again, this is where MR comes in. Now here is an MR image with non-specific contrast media, and this is a rather non-specific appearance. It's a hypervascular tumor, no definite central scar. This is probably not really a central scar, and then contrast enhancement in the portal venous and delayed phases, very similar to normal liver. So again, this could be FNH, this could be adenoma. In this case, it was an adenoma. However, if you use liver-specific contrast media, this would typically be Primovist or gadolinium Bopta multihans, then you do delayed phase imaging, then you see a distinct difference between FNH on the one hand, which typically and almost invariably shows late phase accumulation of these contrast media, and compare this to adenoma, which shows washout of these liver-specific contrast media at 20 minutes and 1 hour. And there are several papers showing that this is really a very effective way of telling FNH from adenoma with a sensitivity of 97 and a specificity of 100% in 108 patients, so a rather large study. So this is really one way to solve this difficult clinical problem. Steatosis has been mentioned, and steatosis can be focal, or steatosis may also be incomplete, and you may get focal areas of sparing. Here is an arterial phase image of a patient who obviously has steatosis. Is very dark. We haven't got an unenhanced scan. We don't routinely perform an enhanced scan, and this was a coincidental finding. We didn't anticipate this finding, but you can see that this area here is darker than the rest of the liver, and also here is an area, so it's a heterogeneous steatosis. And now if you look carefully, you will find that there are several focal, what appear to be hyperdense lesions. And if you follow those lesions like this one here, this is the portal venous phase. This is of the arterial phase, portal venous phase, and then in the delayed phase, you can see that these lesions remain bright and relative to normal liver, really almost the same contrast throughout this scan. And these are not tumors, these are pseudotumors, these are simply areas of focal fatty sparing in a fatty liver. These were, in this case, histologically proven. We've heard about bile duct hamartomas, von Meinberg complexes, also called if multiple, and this is one of the things that shows us our limitations as imagers. You've heard 10% of benign liver are bile duct hamartomas, and there is actually a publication by Karl Hunen from a few years ago which shows that in his necropsy series, 50% of patients had bile duct hamartomas. So these are incredibly common tumors, but who of you has them on your report on every second liver examination you report? None, nobody, because we don't see them. We hardly ever see them. We see them sometimes. I think they are a common reason for false positives in detection studies, be it with anything that you may use for imaging. I'm sure some of those small lesions that we start seeing all of a sudden are in fact bile duct hamartomas, and we can only see them typically when they are cystic. You've heard sometimes they're cystic. When they're cystic, we see them, and then they have a very characteristic appearance, and if you know it and familiarize with it, you will start seeing this. And I see CT scans that look like this, probably about 2, 3, 4, possibly 5 a year. So every now and then you come across those multiple bile duct hamartomas. Now, why are these bile duct hamartomas and not simple cysts? For a number of reasons. Because they're small, because they're tiny, they're really tiny. They hardly ever become bigger than a centimeter. They're typically sub-centimeter and just a few millimeters. And they're not entirely round. If you look carefully, you see some of those cysts are actually sort of triangular shaped. And this is very typical. And also very typical is that they have those small enhancing nodules at the edge here. So they're not completely thin-walled cysts. And this is a very typical appearance. And I once surprised our senior gastroenterologist by putting this in my report. And when we were working out of the hospital at night, he said, Thomas, you've made a very daring diagnosis there, von Meinberg complexes. What is this? I'm going to biopsy this patient tomorrow. I said, well, feel free, but there's no need to. And he called me 3 days later and said, you were right. Okay. There are some pitfalls. Not everything that looks like metastasis, this is something one would probably call metastasis, is necessarily metastasis. It could be benign, like fungal abscesses in this case. The clue here also goes to the spleen, which metastasis typically doesn't do, but obviously there's no way of telling, and these are cases that need biopsy. And this is a lesion also which, to my mind, looked very typically of a metastasis in a patient with colon carcinoma. We biopsied this, and it came back as focal fibrosis only with no evidence of malignancy. We followed the patient up because we didn't believe the diagnosis, and she is free of growth. This lesion is still there, but free of growth at 2 years. How does CT and MR perform when it comes to characterization of focal liver lesions? There are obviously tons of studies, and I selected a few of them here for you. Let's look at this column here, which is the most important one, differentiating benign versus malignant. CT in the range of 70%, not brilliant really. MR does considerably better, and this is, and I may say this ahead of the next talk, in the range of what contrast-enhanced ultrasound also does. Similar numbers here for specific diagnosis, always a little bit worse You don't always get it right. Is this an FNH or an adenoma? This is some things we've discussed. There's room for confusion here. You can confuse a hypervascular metastasis with an HCC, but this is really, as far as I'm concerned, the most important message here. And I think these figures show that CT is better than MR. So, conclusion. When should we use what? What's the role of the different imaging modalities? A few statements, and they may be controversial, and I'm sure we can discuss them. First, as far as, and I think the literature quite shows, MRI is clearly superior to CT, and contrast-enhanced ultrasound is fairly comparable to MRI. Therefore, CT should not be the first-line investigation for characterization of focal liver lesions. But CT of the abdomen is done routinely, day in, day out, around the world, everywhere. And far more CT, abdominal CT is done than abdominal MR. And therefore, benign liver lesions, any type of liver lesions, are a real problem for CT. They occur every day, and CT does a pretty good job at telling most of those. So your typical coincidental finding of a hemangioma is no problem for CT. But if you have a specific question, you should not go to CT, you should go to MR. Or you should go to contrast-enhanced ultrasound, and indeed contrast-enhanced ultrasound should be the first-line investigation for suspected benign liver lesions. MRI should be performed before biopsy. I think that's important. If contrast-enhanced ultrasound is inconclusive, and MRI is the only imaging modality that can reliably differentiate adenoma and FNH. Thank you very much.